Okay, welcome to Obcast. Today we're going to talk about resuscitative hysterotomy and its role in maternal cardiac arrest. I'm recording this discussion from the Developing EM conference in Fiji. It's been a really good week here and a great conference, so I'd definitely recommend it to any of the listeners. And later on I'm going to be joined by a colleague of mine, Colin Banks, who I'll introduce later on in the discussion. We're going to start talking about cardiac arrest in pregnancy, and thankfully it's a rare event. It's one of the few emergency medicine scenarios or then procedures we might perform that affects two lives and therefore could have a 200% mortality rate. But luckily, the pregnant women who generally have a lower incidence of comorbidities, the survival to hospital discharge is potentially higher in this group of women. I think it's fair to say it's probably one of the most challenging scenarios in our specialty, and we'll talk later about how to best prepare yourself and your department for the rare situation of this occurring. We'll briefly talk about the modifications to advanced life support in pregnancy, and there's only two, and that is that there's to be continuous left manual displacement of the uterus, which is preferred over left lateral tilt. And this is performed by just having an assistant pull the uterus from the right-hand side up and off the inferior vena cava. The next modification is to commence a resuscitative hysterotomy by 4 minutes post-arrest. Now, the resuscitative hysterotomy is viewed as an adjunct to maternal circulation as opposed to a mode of delivery, and is indicated after 20 weeks, with the main goal being to restore maternal circulation. Now, in terms of other aspects of advanced life support, the chest compression site is the same as a non-pregnant patient, so the lower half of the sternum. And in terms of indications for drugs or defibrillation, pad placement and jewels, they're all the same. There's no current data on mechanical compression devices, and so at this stage they're not recommended. In terms of the source of these recommendations, it comes from the 2015 American Heart Association scientific statement on cardiac arrest in pregnancy, and all these recommendations have been adopted by various national and international resuscitation associations. In terms of the rationale for resuscitative hysterotomy, there's a few that are worth talking about, but it's important to remember that it's primarily a maternal intervention with the goal of optimising maternal resuscitation. Now, it achieves this via a few methods. Firstly, and most importantly, the idea being it can alleviate aortocaval compression, which in turn improves maternal preload and cardiac output. The next proposed benefit is to improve the effectiveness of chest compressions, and also the chance to possibly improve ventilation and reduce oxygen consumption in the mother. Now, as we mentioned before, there are two patients, and therefore early delivery of the neonate does reduce its risk of hypoxic ischemic encephalopathy and neonatal death, and there's obviously therefore the chance to save two lives here. In terms of equipment, I wanted to make this as simple as possible, and you need a scalpel. Size 20, 22, either one is fine, but the idea is a large bladed scalpel, and I think it's best to have, if you're setting up a resuscitative hysterotomy tray, have two scalpels available, because with poor technique and disposable scalpels, it's, I think, a realistic possibility that these might blunt during the procedure. A set of trauma shears, and these bits of equipment are all you need to do the procedure. Now, following the delivery of the child, I can anticipate you needing a Yenka sucker, a large vicral suture like a 0 or a 1, as well as some abdominal sponges and vascular clamps of any variety available. In terms of performing the procedure, I want to make it as simple as possible. Reading most of the published literature on the topic, it's generally reported in 20 or 15 to 20 steps, and we want to make it here as simple as possible so that it's most easily remembered. The steps we've got here are to establish effective advanced life support with continued manual left uterine displacement, and this should continue until you get knife to skin. It's important that you wear PPE for yourself if possible, and then only undertake a sepsis such as pouring betadine if it's immediately available, and I accept this is probably unlikely to be the case. In terms of incision, just make a large midline incision from the top of the fundus to about 5% 5 centimeters above the pubic symphysis, and just cut down in that orientation until you see the uterus. If you have an assistant that can provide counter traction on either side of the incision, that will make it easier, or you can provide counter traction on the maternal right side of the incision with your left hand. And just do not be concerned with any risk of or trauma to the bowel or the bladder. The gravid uterus actually displaces the abdominal organs superiorly and posteriorly, but having said that, the risk of these injuries occurring really just isn't a consideration that you need to spend any time being concerned about. When you reach the uterus itself, make a midline incision in the lower segment of the uterus. And the reason I say the lower segment, it's very thin there and you'll reach the liquor very easily. And then you can extend that incision with trauma shears, just using your hand to guard the fetus against, essentially cutting its hand or foot. In terms of how to remove the baby, well, it's going to depend on the size of your incision. If you've extended the incision the majority of the uterine surface, then the baby should be very easily delivered. If you're having any problems, some fundal pressure from the assistant might be helpful. Now cut the cord around 5 to 10 centimetres away from the umbilicus, and the reason that is it's going to facilitate an easier umbilical venous catheter, assuming there's a reasonable chance the baby will require some advanced resuscitation. And then continue to focus on advanced life support. And as you'll hear spoken about or read about in other areas, it's often best to have two teams here, a team focusing on the ALS to the mother, as well as a team focusing on performing the resuscitative hysterotomy. At this point, you'll need to remove the placenta. As with achievement of ROSC, this could be a source of significant bleeding. And you can do this at this stage by just putting traction on the umbilical cord across your vascular clamp. But if you're, again, having trouble, you can use your hand just to shear the placenta and off the uterine wall. At this point, you should reassess the mother, and the branches of the decision-making tree here will be whether there has been ROSC or no ROSC. So if you still haven't achieved ROSC at this point, manual compression of the aorta could be of benefit to the mother. I'd advise packing the uterus and just focusing on ongoing advanced life support for both mother and neonate. In terms of if you have achieved ROSC, then again we'll focus on post-resuscitation care of the mother, ongoing neonatal life support, and then just swab out the uterine cavity and close it. But at this point it'd be absolutely fine to have a colleague of yours come to the emergency department and do that. Just want to make a point though, don't close the abdomen itself. It's important that the abdomen can be explored for either contributors to the maternal cardiac arrest, for example, in the setting of trauma, or explored for any injuries caused by the resuscitative hysterotomy, and this is best done in the operating theatre. We've included a more detailed step-by-step approach to a resuscitative hysterotomy, and this is really there just for your reference later on. It's important that it's viewed as a simple procedure, so the few steps that we've just described will be best for you to remember. Unfortunately, if you do get ROSC in these women, it's unlikely that your problems are going to stop there. Postpartum hemorrhage after a resuscitative hysterotomy isn't something that's been discussed or described before, but it's something that's likely to occur almost universally. If you've had a listen to the podcast on postpartum hemorrhage or have some obstetric educational experience, you'll remember the different causes of postpartum hemorrhage being uterine atony, genital tract trauma, retained placental tissue, or coagulopathy. And the reality is that some or all of these will be occurring in your post-cardiac arrest woman. An easy way to remember the management of postpartum hemorrhage, and certainly applicable to this setting, is that the old obstetric mantra of the empty, closed and contracted uterus won't bleed can help guide your interventions. And I've just included a summary box here of some of the different things you can do in the setting of postpartum hemorrhage. I'm going to pause now and introduce my colleague Colin Banks. Now, Colin and I work together in North Queensland, and he's a senior emergency physician who some listeners might recognise from the From Other Journals section of Emergency Medicine Australasia. Colin's got a lot of experience interpreting trials, and him and I have actually spent a lot of time evaluating the data for resuscitative hysterotomy and reviewing other aspects of maternal cardiac arrest. So thanks for joining us, Colin.
It's a pleasure, Ben. It's certainly a great week here in Fiji. Now, resuscitative hysterotomy is probably the procedure I would like to retire without having done by a long way. But it is something I think you need to prepare for, so thanks for doing this. At the end of the day, we're never going to get a randomised controlled trial about whether this actually works or not. Nearly all the evidence that is out there at the moment, it's either case reports or case series, and of course there's going to be a huge publication bias towards those with a positive outcome. Fortunately, there is some registry data emerging, which I think is probably the future for evaluating the success of resuscitative hysterotomy. And just recently, in 2017, last year, there's a paper from the UK, from their already established obstetric surveillance system, which looked at 66 women with cardiac arrests, of which 49 received a resuscitative hysterotomy, and of those, 11 were done in the emergency department. And that's obviously of high relevance to me and where my interest is focused. But unfortunately, they didn't really go into an analysis of the data that explicitly explained or explicitly showed what happened to these women. But reading around it, it was clear that those that arrested pre-hospitally had a far worse outcome, with nearly all dying, and said that, and even the fetal outcomes weren't particularly well described for those that were from the emergency department, but one can only assume that they were worse than those in hospital. The overall maternal survival was 58% for the 66% of cases, which is obviously a lot better than most causes of arrest. But remember, a lot of these are in hospital, and actually a quarter of this registry data, a quarter of the women that arrested were actually as a consequence of obstetric anaesthesia, where you can imagine that the obstetrician's already ready to go, and it seems intuitive that they're going to do better.
So we're going to talk next about when to start a resuscitative hysterotomy. The current recommendation is to start by 4 minutes and aim to have the baby delivered by 5 minutes. Now, this is a really easy to remember recommendation, which is a good thing, but then it's probably rarely achieved in the real world, which is important to remember. There may be some instances when starting earlier will be appropriate, and that might include a case where there's been a maternal injury that's clearly unsurvivable. But for the most part, we feel that the starting by 4 minutes and having the baby out by 5 minutes is a good recommendation in terms of focusing on early commencement and of the resuscitative hysterotomy.
Yeah, but the literature does reflect that this is rarely achieved, and it's important not to rush through this. You need to be smooth and as calm as you can. So look, there was a recent study which looked at which generated a survival versus time curve, and it didn't actually show that a dramatic change or an inflection at the 4 or 5 minute mark. It was pretty linear, as you can see. And then also moving on to a separate study which looked at what the threshold was for injury-free survival, which is obviously what we're, of course, aiming for. And there, I guess their median cases were at 25 and 26 minutes for mother and baby, which is, seems quite impressive, but I think we've just got to keep in mind that this is going to be based on, the case series, which are going to have a publication bias.
So a reasonable recommendation, as far as we're concerned, is that establish ALS and establish it appropriately, but then once that's occurred, then start the resuscitative hysterotomy as early as possible, because what we've learnt from what data that is available is that the earlier this is commenced, it's likely the survival is going to be higher, which makes sense. The last thing we want to talk about is from what gestation a resuscitative hysterotomy should be performed.
Yeah, and so the recommendations are for 20 weeks, and you really should be following the recommendations unless there's a good reason not to. But it is worth just keeping in mind is that there's virtually no evidence that aortocaval compression occurs prior to the third trimester. So it's hard to see how doing a resuscitative hysterotomy for maternal reasons at these very early gestations would work. But these guidelines have been set up to discourage people from not doing resuscitative hysterotomy when it's occurred. So they're nice, simple, clear guidelines to go from 20 weeks.
So just some additional background to the literature surrounding aortocaval compression is that there were some very interesting physiological studies done in the late 50s which looked at women at 38 weeks having elective caesarean sections who underwent inferior vena cava angiograms, looking at the effect of the gravid uterus on the flow back through the IVC. And this research, although very impressively done, it's hard to know exactly how that equates back to the 20-week recommendation. But as Colin said, these recommendations are written for their ease of use and ease of remembering, and there's a lot of grey areas here as to when aortocaval compression commences and to what degree it occurs throughout pregnancy.
Yeah, and now I think this is one of the really challenging questions: is how far post-arrest is it reasonable to attempt resuscitative hysterotomy? Because you can imagine, and particularly again with reference to the emergency department, for women that arrest pre-hospitally, it's very unlikely that the pre-hospital providers are going to call an arrest in a young woman who's pregnant. So you can imagine we're in a situation where a woman who's had prolonged resuscitation is coming into your department. And of course, it's a very difficult question to answer. Looking at some of the case studies, and these, a lot of these case studies we haven't been able to access directly, and we're just interpretations of the case studies. So I think one's got to be cautious, but there's publications saying that the longest time to delivery with maternal survival is 37 minutes. Longest time to delivery with neonatal survival was 57 minutes. And even had there's some cases with good neurological function. As you can see there, at 6 months was delivery at 45 minutes, and good neurological function at 4 years was delivery at 30 minutes. So look, it's very hard to give a clear recommendation for how late into resuscitation should you do one of these. Should you perform a resuscitative hysterotomy? But I do think that you need to think of it. It is a potentially reversible cause of arrest, which is not quite accurate. But if you've got a woman who's got a tension pneumothorax, you're not going to call the arrest until you've relieved the tension pneumothorax. Now, it's perhaps not quite a great example, but I think if you've got an arrested pregnant woman and you do think there's any chance of viability, you're going to have to perform resuscitative hysterotomy.
So then just some final comments on maternal cardiac arrest and resuscitative hysterotomy in general. I think we can agree, and Colin and I have certainly agreed, this would be our nightmare scenario.
Yep. But
given it's such a difficult scenario, preparation beforehand is just so important, and that's in terms of the departmental simulation. You're making your own plans around when and how you're going to perform the procedure, who you're going to involve, what technique you're going to use. If you have the opportunity, learn the skills or simulate the skills. There's been an article presented on how you can make a mannequin to practice resuscitative hysterotomy. These things are all very useful.
But at the end of the day, I think you obviously need to know the recommendations, which are, to perform in a woman that's over 20 weeks pregnant who's arrested, to commence by 4 with a goal of getting the baby delivered by 5. But do accept that there are a lot of grey areas behind this, and these recommendations have just been generated for clarity, I guess.
So that's all we wanted to say about resuscitative hysterotomy. Thanks very much, Colin.
Pleasure.
And any comments or questions, please feel free to leave them below. You can download a copy of the PDF of the slides easily on the website. And thanks very much for listening to Obcast.